I'm gonna call, all right, 6:41. Hello, everyone. I'm gonna call the meeting to order now, with this crazy day. Um, we're always, dealing with the technical aspects, but I was a little late coming in, and so that took a couple of more minutes. Um, what I'm going to do now is ask if there are any additions to the agenda, and I believe you see it there. We may have to scroll it up a little bit, Ashley. And informally, you guys are meeting Ashley Tapia. She is our new community associate. Someone said hello. I heard that. I heard it too. And so she is fantastic helping us out here. And Heather, we kept waiting. I mean, Heather's usually here. She's usually here. Yeah. And so we now have a quorum with, so it's Laquita Henry, Monique Harden Cordero, and Heather Jason here. So we do have a quorum. And I am missing Dr. Torres, who usually takes minutes, but I know he's in exams now, so that's writing a lot of and then actually taking the exam as well. So
Can we set this up so that it does AI and you can maybe
can we do that, Ashley? Can you set it up?
set up so it takes,
So it can,
I guess, notes so that we can maybe convert it to minutes?
Oh, yeah, it's already taking notes.
So it'll be able to
Sorry,
pull it
taking
down?
notes.
Yeah.
Thank you
Yeah.
so very much again. Okay, so please look at the agenda. And just even if you don't see the agenda, because this week before today, I had just sent out who our invited presenters were. But Dr. Gomez, I see you're on. Is there something you wanted to add or be part of the agenda? And then, well, I know Sandra's working on something. There's someone else I saw. Is there anyone on that has something they'd like to add to the agenda? Pauline.
Hi. Hi, Laquita. How are you?
Okay, are you wanting to speak? And well, we always expect you to have something, but I'm not sure if there's anything.
No, I know you have a packed agenda, so I have nothing major to announce, but I'm happy to take any questions or any concerns that the community board may have.
Okay.
Okay.
Okay. And
Great.
then Cheyenne, I'm gonna call on you because you have a lot of programs that you can announce, okay? So I'll add those to the agenda. Is Cheyenne on?
Yes, hi. That sounds great.
Okay, so I think those will be the two added components. All right. So can I get a motion to adopt the agenda as added, modified? Okay, so okay, it's been properly moved by Monique, seconded by Heather, and we all say yay. Yes, yay. Okay, so one of the things minutes. Now Edwin took minutes, and you guys have it just today. It's crazy. I was having computer issues this month too. I did mention that to a couple of people. But anyhow, I would like for us to get a motion to accept as presented, and then we could feature corrections as they may come up. Can I get a motion for that? Usually they're correct.
So move to accept the minutes as presented, barring any minor edits.
Can I get a second, Heather?
Oh, sorry.
And then I'm going to ask, I've already asked Ashley for a copy of the attendance last time, because I know I missed Liz, and then all of a sudden she was sitting right there. So she sneaked in on me. So I thought but she was also on Zoom. So I thought she was on Zoom. So I want to make sure that I have the attendance correct, which you don't see on the minutes here, but I will use the sign-in sheet for that. And Ashley's gonna email a copy of that to me. Okay, so we're set now for announcements. There are a number of announcements. Sandra Harris, our friend at Columbia Irving Medical Center, sent today a clinical trials day event that they're hosting on May 27th. It is a half-day symposium, and it's from 10 to 5. That's a Tuesday, May 27th. It would be so great if those of you who have other healthcare organizations can arrange, I can reach out to you, but can arrange to maybe have a representative. It is similar, actually, the health committee with our public health forum modeled our forum after Columbia's clinical trials day, where they had, it actually was just an evening, a 2-hour evening, but it was fascinating, the research that they had done. If I remember correctly, they had done some research, new research on menthol tobacco. They had research with one component on cancer, and I forget which, I think it was on lung cancer. And then a gynecologist spoke on difficulties, not necessarily maternal mortality, but difficulties of women in pregnancy. And they had come up with some innovative research that they were testing and to date had tested well. So there were 3 presenters. Now it seems at this event that there will be more. I will forward the email. We have oh, Ashley, if you could help me, we can remove the agenda.
I was gonna stop sharing.
Yeah, that's what it's stop sharing. Right. Thank you. So this way I can see everyone.
So this is, okay, so it's all day on the 27th. And Cancer Center will raise awareness. And you said this is different, but this is not a part of the community scientists? That's the question I want to
No,
ask.
no.
Not at all?
No, it's not. They're gonna present the trials that have been worked on. Some of them maybe 5 years, some of them
Oh, is there
maybe
data
2
from
years.
that? Okay.
And and they'll talk about community outreach and engagement. Now, interestingly, since I don't see the names of the participants, there could very well be someone from the community scientists.
Right, because they partner with them, I think.
Yeah. I will get this out because it just came today. I'll get this out to everyone and we have additionals here. Okay, so that's what I have. Also from Columbia and Diego Quintuna. Diego has sent information on a health fair. That's one piece that takes place on May 10th. On West 175th Street. That's outside of our district between Broadway and Wadsworth, but I have gone up there different times and, I remember Dr. Gomez presented something that was wonderful and they had a really terrific turnout in that particular area. So anyway, it's a health fair. I will send that out as well. And just to wrap up with what Diego sent us, hold on everyone,
What's that date again?
May 10th.
Saturday. And what time?
Interestingly, 11 to 3. 11 a.m. to 3. And then he has sent something in terms of May community updates as well. There's an early detection of Alzheimer's event. Um, expanded screening for Lynch syndrome, cannabis use disorder.
Oh,
I'm gonna send this out. This just came today too.
okay.
Cerebral palsy community day. And then there's Manhattanville Community Day.
Oh, wow.
Let's see. I'm gonna get this out tonight because I'm not sure. Let's see, Monday, it seems like Monday, May 12th
Mhm.
is the early, oh no, there's another May 10. So, anyway, I'll get those out after the meeting, okay? And, there is, there's something else, seems like there was another announcement. Does anyone out there among our Zoom partners have an announcement, upcoming event or screening? These are really important. There was one thing that I forgot.
You said 11 to 3 on what day?
11 to 3, May
May
12th.
12th.
Yeah, May 12th.
Oh. Right,
And
that's
then,
on Monday. I'm sorry, what is 11 to 3 on May 12th?
I'm gonna have to send it out to you so you can see the whole thing,
Okay.
but, huh, oh, that was the health fair.
I thought it was on May 10th.
Well, let's see, probably is May 10th.
That's a Saturday.
That's why I don't wanna get, because I'm having to go from one document to the other, I don't want to
Okay, you'll send it out.
screw up. But both events have come from,
Diego?
Diego Quintuna, connected with, the community outreach at Columbia. Cheyenne, do you have announcements? I've sent out some of yours, I hope you saw that, I sent several things out.
Hi. Yes, thank you so much. And I do have a couple of events I'd like to share.
Yes.
Two of which I've already emailed, but one I haven't had the chance to yet. So I'll share all three.
Okay.
The first one is our event tomorrow. Oh, by the way, hi everyone. Good evening. I'm Cheyenne Murillo. I am here on behalf of the Harlem Bureau of Neighborhood Health. So tomorrow we're having our World
Cheyenne,
As
excuse me,
yeah.
Cheyenne, is that her area is part of New York City Department of Health and Mental Health?
Yes.
Okay. Yeah, okay.
So tomorrow we're having our World Asthma Day as part of our unit at the Department of Health. We have the Asthma Center for Excellence in East Harlem. So they're hosting an World Asthma Day tomorrow at the Action Center on 115th in between Lex and 3rd from 10 a.m. to 4, where they're going to have food, they're going to have activities. I believe they're giving away air purifiers and other asthma related goodies like sheets and things like that, and also non-asthma related goodies as well. They're doing face painting, drawing, things like that. So that's tomorrow from 10 a.m. to 4, and it's a lot of fun. I went last year. I'll be there too, so I'll be there helping out. And that's at the Action Center, and then so that's tomorrow, and then on May 15th, one of our partners, New York Fondling, right down the block, is having a mental health community day of action where they're going to be having mental health activities for the whole family, snacks, free raffles and giveaways, and connections to community resources within mental health and beyond. So that's May 15th from 3 p.m. to 6 p.m. And the last one that I'll highlight here is the NYCHA Know Your Rights presentation happening on behalf of the New York Legal Assistance Group and Legal Hand. So they actually have Legal Hand has a clinic at our shop where folks can, at our place where folks can come in and ask legal related questions. So this one is focused on NYCHA, and they're going to be covering succession rights, repairs and maintenance, understanding your lease, reasonable accommodation, and transfer request. So this is awesome too because you can join in person, which is going to be in East Harlem at the Action Center, or you can attend online too. So that's really accessible and great. And then you'll be able to participate in a Q&A where you can they'll answer to their best of their ability, real-time questions. So I haven't shared that one out, but I'll share it right now. And I can give you that link as well. So those are the three things I wanted to highlight.
Okay, And if you want to drop anything in the chat, you know, the flyers and all, if it's
Yeah.
accessible for you, then do that, because at least with this particular audience, they would have it and can share it with their constituents.
Sure. I think that sounds good. I think you might have to upgrade my status so I can have access to the chat. Oh, I'm just kidding. I can see it now. Never mind. Ignore me. I'll put it in the chat.
Okay, great.
I'm sorry, the mental health day, which is on May 15th,
Mhm.
where, the location is at the East Harlem Action Center?
No, I'm sorry. That's going to be at the New York Fondling, which is 109 East 115th Street at their home of integrated behavioral health. And I'll put that in the chat too.
Okay, East 109, East 115th Street,
Yes.
New York Fondling. Oh.
Okay. And let me mention, thank you, Cheyenne.
You're welcome.
Let me mention another, we are partners with CUNY, CUNY School of Public Health. And Deborah Levine is often at our meetings via Zoom and participated in our forum. So you may be familiar with her name. At any rate, they are hosting, in conjunction with Community Board 10 and the School of Public Health Foundation, as well as New York City Preparedness and Recovery, a special community event unveiling Trace. And Trace is an evocative artwork dedicated to honoring the remarkable individuals who demonstrated extraordinary service during the COVID-19 pandemic. So that will take place on May 28th. That's a Wednesday, 5:30 to 8. And it will take place at the CUNY School of Public Health, 55 West 125th Street, the ground floor. They anticipate a gathering of community leaders, residents, and stakeholders who have been instrumental in fostering resilience and solidarity throughout these challenging times. And the artist is Nisa Chow. Some of the honorees will be Professor Dominic Boyce. He's also vice president of the NAACP Mid-Manhattan branch. Deneen Brown Blackman, a lifelong resident of Harlem, who's on a number of boards, and she's works in government, dedicated public servant. Dr. Cheryl Smith, who was deeply moved by the stigma surrounding HIV patients, and the site was inspired to focus on HIV care for the past 30 years. She's been a dedicated HIV/AIDS doctor. So that, again, I'll send this out. There's a lot going on. So at any point that you have information to share, send it as far in advance as possible, so that we can get it out. And now that we have a community associate, Ashley, who's handy on the technical side, I'm hoping we could get our committees like more website online information that you guys can plug into. Okay, because there's so many articles we need you to be on top of. So, Pauline, do you have anything to share? I did ask you before, but is there anything that any of you are going through that you need information on from the Department of Health and Mental Health? How's the measles?
So far we're good on measles. We had 3 cases, no new cases, so that's good on that end. But we are still, trying to educate folks to make sure that they are vaccinating their children. We know after COVID, a lot of children fell off their vaccination schedule. So we're just encouraging parents to go back to their pediatrician and to make sure their kids are on a proper vaccination schedule. But also, all school age children in New York City are required to get their MMR vaccine. So that is also a way that we can help make sure that disease doesn't spread around in our public schools. But so far, so good on the measles front.
Okay. What about, what's the latest on COVID? Because COVID was pretty bad this year, but there wasn't a lot of talk, and a lot of people didn't talk about it as much. I tended to hear about it after the fact, after someone recovered or semi-recovered. And that's the way people were kind of, low key about it. I think they know the fear COVID has, so they didn't want to add to it. But what's the latest on COVID?
Yeah, COVID was sort of an issue over the winter months. We did see a lot more cases of RSV and influenza A. And so we actually ended our flu surveillance back in March, I believe, or early April. So hopefully it's the end of flu and COVID season. But we still have data for COVID on our website. So if anyone is interested in delving deeper into that data in terms of zip code information, that's all on our website. And it looks as though for the last 7 days, total cases in the entire city were about 292 that were diagnosed. So the numbers, it's also difficult to tell because, of course, people have to go get an actual diagnosis for COVID for it to show up in our data. So a lot of people were getting sick and, testing at home or not testing at all. So it is really important that people, if you're not feeling well, to stay home. But if you are concerned about whether or not you have COVID, obviously go get tested. That information does help our data. But we do encourage people to then mask up if you're in, close quarters with anybody else, just to protect yourself and protect other people. So that's the information on COVID. And then I just highly encourage everyone to visit our website because we do put out a lot of press releases and interesting reports. We had a report that came out in mid-April about immigrant health, and overall, in general, immigrant New Yorkers fare slightly better than native New Yorkers when it comes to health outcomes. And I think that's an interesting statistic for people to look through. But of course, there are still some things that we can improve for the health of immigrant New Yorkers as well. But that's, that might be something interesting for your health committee to look through. And if you have any, questions on that or want to delve deeper into any of the topics, please let me know and I can try and bring in an expert to give you all a presentation on that.
That would be great, maybe for our June meeting in particular. So let's try to see what we can pull together where we've had a number of questions and see what area would be great. Because I know you did that for us earlier in the year too, I think in
Right.
September. So that would be great. So let's look to try to do that in June, which is our last in-person meeting.
Sounds good. Thanks, Rita.
Thank you. Okay, so we have some very interesting presentations, and probably two more than one. Let me kind of turn it around a bit. Is Dana Hale here? She may not have come yet. She called me earlier. Okay, so we'll go back to the original lineup there. I had an opportunity to hear in a community stakeholders meeting. The state community stakeholders sessions were pulled together, coordinated, designed by Dr. Judalise Gomez, and they have been absolutely fascinating, featuring researchers, doctors who have particular topics that they've studied, done investigation on, and had this opportunity provides them a chance to present their data. And in this particular case, with the community stakeholders, they've run for the last year and a half. All of them very exciting, maybe just 3 a year because of their quarterly stakeholders meetings. Unfortunately, due to funding cuts, they'll have to curtail the program after this last meeting this past week. But we're hoping that funding will, especially when you have good programs like this, excellent educational health topics as the ones that come before us with community stakeholders. So I'm hopeful that they'll continue because it's too worthwhile not to. So thank you, Dr. Gomez, again for putting it together. And we have
Thank you.
speaking, yeah, Dr. Megan Redding, and you will, I don't want to butcher your last name, Churchio. Okay, you got it. I saw
Yes,
it
that's
now.
correct. Yeah.
Okay. Who did a study on a cardiovascular study, atrial fibrillation, and monitoring the heart on devices. I sort of came up with that topic, but you can give the full topic, Dr. Megan. Um,
Okay.
and let's see, I we hooked you up as a co-host. So do you have your slides set up? Yes.
Yeah. Can you see this okay?
Yes.
Okay, fantastic. Well, great. Well, and I don't want to take up too much of your time because I know you have a packed agenda tonight, but I just want to thank you very much for the invitation. It's wonderful to be here. So, my name is Megan Tertio. I'm an assistant professor at Columbia School of Nursing. And as Laquita said, I was a recipient of one of the pilot grants that was funded through the community center, which Julius Gomez has coordinated and led for the last several years, and it's been a real privilege to work with that group. So, I'm going to talk to you a little bit about the topic. It's focused on atrial fibrillation, which some of you may have heard of. We're talking more and more about it sort of in social settings, but it's a cardiac rhythm disorder, a heart rhythm disorder where the different chambers of your heart don't beat regularly, so it causes these chaotic, irregular heartbeats. It is actually the most common heart rhythm disorder. It affects about 6 million people, but the number is about to double because all of the risk factors for atrial fibrillation are increasing. We see this mostly in older adults, like ages 55 to 65 and older, but it is also occurring quite a bit in younger folks who may have risk factors. Sometimes we see it in patients who've had pregnancy related complications and there's strain on the heart. So we can see it really at any age, but it's mostly in older adults. There are different risk factors for it, as I mentioned. I'll just briefly touch on heart failure, which is one of the risk factors for it. Um, it's a very difficult it's very difficult to detect because it's not like you're in this rhythm all the time. You kind of come and go in this rhythm. So it's episodic, it's unpredictable. And sometimes you'll have really clear symptoms and you'll know, ooh, I'm in an episode of AFib. And sometimes you don't. Sometimes you're kind of just feeling tired or maybe you don't have any symptoms at all. So it's actually really hard to know when you're in or out of this rhythm. And what you need is you'd actually need an EKG to tell you what your rhythm is. Now, if you go to the doctor when you're in this rhythm and they do an EKG, they can find it. But the challenge is that you might go to the doctor and be perfectly fine and then go home an hour later and start having AFib and you won't know that you have it. So it's really tricky to detect.
Mm.
We care a lot about detecting it because if you don't detect it, you're at a 4 to 5 times higher risk of having stroke compared to people who don't have AFib. In fact, something like 1 in 5 strokes are actually caused by atrial fibrillation. And what we see is that patients come to the hospital, come to the emergency room. Unfortunately, they're having either a mini stroke, which is called a transient ischemic attack, or TIA, maybe you've heard of that, or they're having a full stroke. And when they do some investigation, they discover this patient actually had AFib that we didn't know about. In fact, one study thought that it estimated that about 40% of patients who have no history of cardiovascular disease and showed up to the emergency room with a stroke actually had undetected AFib causing the stroke. It's important to note that there are a lot of risk factors, right? So, smoking, alcohol consumption, inflammatory diseases, a lot of different chronic conditions can cause increased risk. It doesn't mean it's going to cause AFib, but you're just at a little bit of an increased risk for this. And so, you can see the list here that I'm showing in the figure on the right-hand side. And the reason we were really interested in partnering with the community about this is because we're concerned that we're not doing a good enough job of managing proactively the risk factors and identifying AFib early in members of the community. We know that, for example, Black and Latinx individuals have more AFib risk factors, but we see that there's a lower prevalence of diagnosed AFib. And there have been some studies that have come out that suggest that what's happening is we're actually just doing a poorer job of giving appropriate diagnoses for this disease. So, for example, there was one study that strapped ambulatory electric EKG monitors on white patients and Black patients and showed that there was actually similar burdens of AFib, but the white patients were a lot more likely to actually get a clinical diagnosis of AFib. So the gaps are falling apart here in the health system in terms of the pathway from early detection to diagnosis to appropriate treatment, and it's resulting in poorer care. So we wanted to really tackle this with a lens of understanding this from the perspective of the community. This is actually a screen grab from the community grant that funded this work. So this is what Dr. Gomez was a part of. And we, just to echo you, Laquita, we really hope that we'll find a way forward to continue this really important work, even in the context of funding limitations. So we had two different prongs to this project. I'm not going to go in depth. I'm just going to give you the takeaway message from each of them. The first prong was to really look at population level, what was happening at our health system. So we're up at Columbia Medical Center. We're affiliated with New York Presbyterian Health System. And so we looked at actually the electronic health records data from New York Presbyterian, and we looked back over 10 years. And once we pulled that data and analyzed it, we were able to look at this question actually of oral anticoagulations. So, what you would like to see is that if somebody is diagnosed with atrial fibrillation, most of the time you want them to be put on an oral anticoagulant pretty quickly, within a few months. There are some nuances there. There's some clinical decision making. There's some shared decision making with patients deciding what the right course of action for them is because it's not always clear. But in general, it's kind of considered a quality measure that you would like to see oral anticoagulants. So oral anticoagulants help people prevent their strokes if they do have AFib. It's a very effective way as soon as you're diagnosed with AFib of reducing your stroke risk and improving outcomes. As I said, they should be prescribed soon after they're diagnosed, but there is a lot of concerning evidence out there that we see long delays, especially for racially and ethnically minoritized people and people who don't speak English as their preferred language. And the delays potentially could be longer depending on where you're diagnosed. Did you first discover that you have AFib in the hospital, or were you first diagnosed in an outpatient doctor's office? There's some evidence that that's connected too. And what we did was we actually looked at the relationship between race and ethnicity and where you were diagnosed. And the gist was that when we looked at over 21,000 patients treated over 10 years at our health system, we found that actually there's this relationship between race and ethnicity and diagnosis location that does impact how quickly somebody's put on anticoagulation. So there's kind of a nuanced set of results that I'm not going to go into for the sake of time, but it tells us that
Yeah,
it's
you can go into it a bit. We have a change with one of the presentations to June, so you have a little bit more. Go ahead. I'm
okay.
important.
Okay, thank you for letting me know. Thank you. So what we saw was that um, race and ethnicity sort of interacted, we say kind of statistically, with diagnosis location. So we saw that certain racial and ethnic groups were being diagnosed in the outpatient setting less. And that's important because some research is sort of a good way of measuring how early or late in the disease course you were diagnosed. So that suggests to us that we're not catching AFib early enough in these populations. But the good news was that when we did catch AFib, we actually were doing a pretty good job of getting them on oral anticoagulants quickly. So it might be, we don't know exactly why. There's been a lot of quality measures and sort of quality improvement programs that are focused on oral anticoagulation. They're looking at that measure really carefully. So that could be a big part of it. And so it tells us if we can diagnose this quickly, we are kind of doing the right thing in terms of getting them on oral anticoagulation in an appropriate time frame. But we need to probably do more research on the topic to understand how do we do that first piece, right? And that's what this second piece of the second prong of the research study really focuses on. So the second prong was asking how can we better detect atrial fibrillation? So many of you may have experienced going to the doctor and being hooked up to this contraption. It's like a huge machine, and this is a 12 lead EKG. So you lay down, you get strapped up to all these leads, and then they take a 30-second snapshot of your heart's rhythm, and that's an EKG. As I mentioned before, it's great at diagnosing certain problems, but it won't catch AFib if you're going in and out, in and out. You may catch it, you may not. So we've seen in the last 5 to 10 years that there's been this rise of digital health tools to help us detect atrial fibrillation. So as we've seen things like smartphones, smartwatches become basically everywhere in society, especially smartphones, not so much smartwatches. We've seen a lot of really cool technologies. So, for example, I don't know if you can see my mouse, but like this app that I'm showing you here, you can put your finger over the flashlight of your smartphone, and the app will actually sort of read your pulse through the flashlight. And there's an algorithm in the app that can do a pretty decent job of determining if you're having an irregular rhythm and might be in atrial fibrillation. And the beauty of this is that these apps are free or about 99 cents at most. So these are a really cost-effective, widely available solution. We've seen some slightly more sophisticated technology down here. This is a device that works with a smartphone, and you can purchase it for about $80, I think. It's called the the AliveCore Cardia device. And you take a little EKG with just putting your fingertips on the device, and there's an algorithm that can read the EKG and say this is likely AFib or not. And then some more kind of expensive technology would be like the wearable that a smartwatch like an Apple Watch that's on your wrist, and it can do the same thing. It can detect AFib. So these are really exciting, and I think when these all came out, everybody thought, "Oh, this is great. We're going to solve this AFib problem." And of course, that's not how it's played out. And a big part of that is that the people that are sort of organically using these technologies because they think they're cool and they want to play around with them are not actually the people who are at the highest risk. So the people using digital health to monitor their heart are not the people who need it the most. So I think the perfect example of this was this big study that was done several years ago now. It was called the Apple Heart Study. It was done out in California, in Silicon Valley, where all of the kind of tech startups are. And they partnered with Apple, and they recruited 419,000 people to use the Apple Watch to monitor for AFib. They just basically enrolled everyone who had an Apple Watch and sent them a little notification and said, "Do you consent to being part of this study? Like, do you consent to us using your data for this study?" And that's how they were able to get so many people. And what they found was that only less than 0.5% of all those people actually received a new diagnosis of AFib based on their Apple Watch. And I think when you look at the demographics, it makes perfect sense. there was low representation from Black and Latinx people. There was 6% who were age 65 and older, and only 0.5% had heart failure, which I mentioned earlier is a risk factor for AFib. So we're seeing that basically the whole population was relatively young and healthy, and there wasn't a lot of new AFib that they found. So I think we took this to mean we have to sort of dig a little bit deeper to understand, is there potential to use digital health with different members of society who are at risk for AFib, or do we need to think of a different approach for better detecting AFib early? So we really wanted to identify the facilitators and barriers of digital health, look at ethical considerations alongside this, because I think it's so important to think about concepts like justice and trust in the context of these questions, and then think about proposing some strategies. And we actually used the social ecological model for our data collection. We did several interviews and we looked at different factors all the way from the individual level, like what is your personal level of comfort with technology and how much are you somebody who really likes new technology versus shies away from it, all the way up to societal levels, like how expensive is this technology? How difficult or easy is it for different individuals to access care, and all the levels in between. We ended up doing 25 interviews. Most of them were in English, but a few of them were conducted in Spanish. And this is where I just have to give another shout out to Dr. Gomez again, because she was totally instrumental in helping us get connected with the right people in the community who could give us the most important perspectives. We came and we presented at the community stakeholder board, and a lot of people there were so supportive and raised their hand and said, I'll talk to you. And so we were able to get fantastic perspectives. This included 9 patients who had either cardiovascular disease or heart failure specifically, so meaning they were at risk for AFib but may not necessarily have AFib. We talked to doctors and nurse practitioners. We talked to caregivers of people who were living with cardiovascular disease, community health workers, and we talked to other community stakeholders such as community health leaders or pastors in the community. And what we found, just as a high level, was that digital health devices really can enhance AFib detection, but they're going to require equitable implementation, meaning there are a lot of barriers, I think 9 barriers that we identified to implementing, all of which could create disparities in how these health devices are being disseminated through society and used to improve outcomes. One of our biggest takeaways, I said this on the last meeting and I'll say it again, community health workers were the heroes of the story. We heard over and over again from both the health workers and the patients how important they were in reinforcing positive health behaviors, in getting patient education about different diseases out there in the community. And so they're really, I think, going to play an important role in this sort of trust building and education work that we want to do. As I mentioned, there are significant financial barriers, not just around the technology itself, because I think we can overcome those, for example, by getting grant funding to give out devices and pay for plans and things like that. But higher level, thinking about the cost of getting healthcare in the United States and the cost of insurance, and if you don't have insurance, all of the things that I'm sure you're all very aware of that are just kind of piled on top of that. And it's important to acknowledge that this was not prevalent, but there were some people who had systematic distrust in research and in the medical establishment, and that could limit adoption too. So what we would like to do is really promote community-centered digital health solutions and or just patient education solutions. Maybe this isn't about digital health, maybe it's just about getting education out there. But we want to continue partnering to figure out what that will look like. If digital health is the answer, we want to figure out solutions for addressing affordability and accessibility of these screening tools, and really looking at the ethical considerations more closely. And this is a figure that one of the wonderful postdocs in ethics who we worked with had put together that really highlights the on the green around creating a community-centered approach that features education, trust building, community health workers, and partnering with community clinics to address this problem. So I think that's all I have. Here is just a thank you to everybody who was a big part of this. I think I'm just going to pause. I'm going to stop sharing and open it up to questions or discussion that anybody has.
Thank you so much. Let's see, are there any hands up for questions? My, let me just add, my mother had AFib, and it was a big deal when, I guess it was highlighted. President George W. Bush, the father, um, was diagnosed with AFib. And that's when it really went, across the country and more people became aware of it and all. Um, I hear of people taking Coumadin,
Yep.
but does that mean that they have AFib or could Coumadin be for something else as well?
Yeah,
But
that's a great question.
a lot of people taking Coumadin, so I'm assuming more people discovered that they had AFib.
Yes. So it's a great question. Coumadin is one of the anticoagulants that I had mentioned. It's actually the oldest one. It's been around a long, long time. They have a newer class of medications too that you might hear about, like Xarelto or things like that. They're always doing like commercials on TV, so people know the names. So you often will hear that people are taking them for AFib, but not always. So, another reason why somebody might be taking them is if you have a blood clot, in your leg, for example, like it's called a DVT. Or if you have a blood clot elsewhere in your body, sometimes people will be taking the blood thinners for that as well. But often there is an AFib. It's the prevalence is about 10% in older adults. So it is fairly common in older adult populations.
And I know there are distinct advantages to Xarelto over Coumadin. It's like with Coumadin, you have to watch your diet. Very limited leafy greens, although they're changing that a little bit. With my mother, I was able to give her a little bit more. They wanted at least to have the same portion each week or the same amount, whether it was 2 days a week, whatever the ritual was or regimen, keep it the same. Whereas
Oh,
with
interesting.
Xarelto, or Xarelta, I don't think it's the same. I think they can eat anything, if I
That's
remember.
that's correct. Yes, exactly. There's vitamin K in leafy greens, and the vitamin K is actually an antagonist for Coumadin. So what that means is that it undoes all the effects of Coumadin. There's so many pros and cons. So just like to give a high level, as you mentioned, you have to watch your diet on Coumadin. You also need your mom probably had to go for blood testing. Is
Mhm.
that, yep, you have to go get your blood tested regularly to make sure that your levels are therapeutic, they're in the right window. One of the good things about Coumadin, even though, well, two good things, it's very affordable because it's off patent, so it's generic. You can get it much more, it's not super affordable, but it's much cheaper than the others. And because there is an antagonist, if you were to, let's say, fall, and let's say you hit your head, they can actually give you a shot of vitamin K to stop the bleeding. So it's helpful for reversing bleeding. Whereas the newer medications don't really have that ability. We don't have anything to kind of stop the bleeding if you start bleeding. But the good thing is that you don't have to get your blood tested. You don't have to watch your diet. They're kind of easier that way. They do tend to be a little bit more expensive though. There are actually a number of excellent shared decision making aids that walk people through different anticoagulants and pros and cons. So if anybody has somebody in their life that is thinking about this, I'd be happy to send that along and send some examples because they really are great patient education resources.
Thank you. Let's see. Does anyone see any, Heather, you see any other hands up or Monique, any other hands?
I don't think I see any.
Um, you were so thorough and easy and clear to understand.
Well, thank you. Well, I would just ask if anybody has any thoughts on or recommendations, maybe success stories they've seen for other conditions. I know Like hypertension is something that the word's really gotten out there. There's a lot in community health fairs, blood pressure screenings. If anyone has best practices or recommendations for how we can start to kind of tackle this, I'd love to hear them.
I have one other question related to the research. It when Apple was Apple given any instruction as to how to not filter but look for people of color, a very diverse range, as they, got 419 or 190 participants. Were they given any particular guidelines in terms of what
That's
would
a
be?
great question. I don't think so. I'd have to, I can pull up the study and see who funded it. Because it used to be that for a time, NIH funded studies would look for representation, as you probably know. But I don't know if this was funded by NIH or if it was like industry funded. You know, if Apple funded these, I believe they were researchers at Stanford who did the study but partnered with Apple and may have been funded by Apple. I have to take a look at the paper. So it doesn't appear to me that they had those requirements, and that might be why there's not great representation in that study.
That's one of the push that, we on the community board and those of us who have gone further to look at research, or we're trying to encourage, well, with our public health forum, trying to encourage more people of color to participate in research. There have been some resistance, but I think that there's more now. As I watch different stories on television, a little bit more on medical research, not where it should be, but then the researchers also have to be engaged and in their heads say, look, we have to make sure that with this common disease that we're getting representation
Yep,
across the board.
absolutely.
For example, with the latest Alzheimer's study, there are a lot of African Americans and I think, probably a number of people of color are noted to have increased in that designation of having Alzheimer's.
Hmm.
But if the latest research, as I understand it, did not really include a sizable or reliable number of people of color, so as to see if the new medication would work. And it was in our committee. I know it was Monica who brought it up. Said that it doesn't look like it's going to be something that we can rely on among people of color to be effective. And so that's really disappointing. We have to investigate that further to see how much truth there is. But it's important for the researchers. I'm so glad you brought it up and you have your eye on the ball with that.
Yeah, I mean, the information, you see more on TV in terms of talking about AFib for sure. I forget who the pharma company is.
Probably zero.
It's so many, but
Mhm.
but getting that out there and understanding that it's more common than we know is so important. And bridging the gap to let people know there are ways at least you can begin to monitor yourself, to have some control over your health, or in some way like you do with your blood pressure, is encouraged for you to know what your blood pressure number is so that you can take steps to change your behavior to improve your outcomes. So the use of Apple, and I happen to have an Apple Watch. Who knows if I can afford the next one? Or we're not going to go into that. But using, right, I do try to use it to help monitor my health. And, not everybody can do that. So bridging that gap in terms of affordability and access is so important. And I think all we could do is continue to, bring that up and also work on ways to just try to bridge the gap. But everything you shared was very clear and important work. So thank you.
Thank you. And just want to highlight both of those comments as like, underscore, thumbs up, completely agree with both of you.
And how, say once again, I believe you mentioned it, but how do you intend to expand on this study, on this initial research?
Yeah, that's a great question. So we've been eyeing different funding sources to be able to do a broader partnership. We'd love to be able to do um, we're not sure exactly. It depends a little bit, right, on who funds it, like what exactly aligning with priorities. So for example, PCORI is one that we've been looking at because they want you to form your own advisory board. And so members of the
Oh,
so that's one that we've been thinking about to bring education, bring technology into the community and try to sort of upstream prevent these AFib-related complications.
Yeah, funding I can imagine is very critical, especially given what's happening now.
Yep.
So,
Yeah. Yeah. No, we'll find a way. And the Columbia School of Nursing also has a nurse practitioner practice. It's an entirely NP run practice. They do a lot of work in the community. If you haven't met them yet, they do a lot of health fairs. They go out and they do screenings. So we're really thinking also about partnering with them because they have the kind of like healthcare delivery vehicle, and we would like to do some more kind of AFib specific education and screening around that. And I'd be happy to put you in touch with them if you haven't met them yet.
I would like that.
Okay, great. I'll gladly do that.
Thank you. And now what I'm going to do is try, let me see. Thank you again, Megan, so very much. And we hope to see more of you.
Thank
Continue
you.
our
Thank you
group.
so much, Laquita. Thank you for the invitation. Thank you all. I unfortunately have to drop off now, but please feel free to contact me if anyone has any follow-up questions and we'll stay in touch.
thank you.
Thank you.
Just check. Bear with me because I talked to our Dana, and it's certainly if there's something technical, it'll be on my end. Let's see if unless Dana's on under a different name. Oh my goodness,
Keep learning something.
because I noticed there were some people in that waiting room situation here, so I did admit.
How did you, okay. Oh, at the top it said.
Yeah, maybe let's see. Hello? Hello? Oh, that's me. Bear with me. Uh, I may not. Dana? I know she was trying to get her. Let me get out of Zoom.
Hello?
My same.
Hi, is that Yana?
Yeah,
Hi, Yana. Do you have something while I'm doing this? Feel free to speak.
You need
uh,
to.
yeah, hi, everybody. Sorry, somebody else was meant to be here, so I'm not totally prepared, but we just wanted to advertise our upcoming event.
Oh,
Uh,
sure. If you do that, Dr. Ronstrom is head of the COTA Alliance. So if you speak on that, I'm just going to try to reach someone who's supposed to make a presentation, but go right ahead, Dr. Ronstrom.
okay, thank you. Well, just quickly, our Saturday morning free yoga for women is continuing. It's Saturday mornings at 10. We are also having on Thursday, we have our doula circle, which has met several times now. That this is to support doulas in the community, of whom there are too few because they're a great intervention for the problem of maternal mortality and morbidity among Black and Brown women, which is a real problem in this country. We're also having a Coda Wellness Day on the 17th, Saturday, and other events which are not health related, but a community potluck celebrating Juneteenth, that's in June. All of these are available on our event website, so I'll put that in the chat if you want to check it out.
Yes, please do.
Thanks so much for
Which
letting us
park
do
are you
that.
in for the yoga, please?
I'm sorry?
You said Saturday mornings at 10 in the park for yoga. Is it?
No, not in the park, inside at Coda Nest at 43 St. Nicholas Place.
Oh, okay, got it. Thank you.
Yeah. But please sign up via Eventbrite. I'll put the link to the event page here in the chat.
And I hope to make it, here's what's happened. Dana had joined the meeting. She was at the office and couldn't stay much longer.
You spoke
And
to her?
then she sent me an email
Okay.
while I was listening to the first presentation. So she may have left, which I actually think that's what has happened now.
Okay.
And this joined in the chat, that component, I don't know what that's all about, but okay. So I'm sorry to have missed the presentation on the burn center at at New York Presbyterian and Weill Cornell. It seems from the email that just as I mentioned, she was unable to stay at the office any later. I guess there was a cutoff, and she was doing all of this from the medical center. So she wants to reschedule for June. So okay, we'll probably have a packed meeting in June. So thank you. The next, I actually had moved this request in the resolution for Columbia to study the effects of the use of microwave technology to June. I've been trying to reach on one attempt actually, Dr. Dye, who is one of the ones heading up data technology as they look at the impact of microwave technology, which is also in the 5G towers, used for that, and other technology as well. So what I have here with the committee is a resolution that we could, and just requesting, not that we know, I do want someone to present on it. Odette Wilkins, who heads up the New York City Alliance for Safe Technology, presented to us a year or so ago, and she's come to our meetings, and she was at our meeting two sessions ago as well. So I can ask her to come back, but I wanted someone from Columbia because Columbia has a number of a smart cities program, a smart center. And so I'm really interested from the environmental angle to have them participate with us and to help inform our community of certain environmental impacts. That's a broad statement, but it can be broken down into other compartments and components to get a jump on what's being studied and how this may impact us, whether negatively or positively. Of course, positively, but oftentimes there's so much going on and so much gets approved on the technical side in particular without our having weighed in at all. And before we know it, it's upon us. And then our community, when I say our, generally it's low income communities that become a pilot project for so many of these projects. So at any rate, I'm gonna try to get someone here for the June meeting, but just so many of you can hear our resolution, and you might have some input as you listen to it. And I see Diego is on the phone, on the Zoom there. At any rate, if any of you can, shed more insight, but I think it's a good resolution for us to have. Community Board 9 requests Columbia University document existing and future campus sources and levels of electromagnetic fields and wireless microwave exposure. Okay, trying to get a head start on this. And so whereas there is good reason to question the public need aesthetics, safety and health impacts of placing 5G for GLTE microwave towers in densely populated areas. And whereas CB9 has formally adopted a moratorium evoking the precautionary principle in rejecting the installation of 5G telecommunications towers. We did do that in our first resolution in its jurisdiction. And whereas it has come to the attention of CB9 that a 3-story high-powered antenna has been erected at the main entrance to the Columbia campus. And whereas this presents a potential increase in exposure of students, staff, the public, and nearby residences to increased electromagnetic fields and microwave radiation. And whereas Columbia University is embarking on several smart development and demonstration projects that may further increase the occurrence of electromagnetic field and use of wireless sources of microwave technologies. Be it hereby resolved that CB9 requests that Columbia University perform a testing program to establish the baseline current levels, mapping of exposure to wireless radiation and EMF, and be it further resolved, the CB9 requests that Columbia University engage in an environmental quality review process focused on identifying increases in exposure to and mitigating impacts from EMF and wireless microwave radiation during smart design project development demonstration. So I mean, I think that's pretty reasonable, and there is so much talk, and I'm not sure how fast things are moving, but apparently this is happening. I'm gonna have to text or email a letter of request that, we'd love to have them come and present to us. But that's reasonable. And then I would also like to have We Act Environmental Justice also present. Perhaps there could be a forum or Q&A on this. Is there any feedback, or what do you guys think of that?
I mean, I think it's pretty straightforward in terms of intent and asking for Columbia's willingness to share, I think, right, data, focus on that.
Whatever they know now, yeah.
Yeah, I mean, I don't think that's unreasonable.
Or to request, because the next thing you know, we have all of these towers and all around us, and there's an impact. We don't, and it could have been something that could have been moderated, especially if found to be harmful. And I know there's not an intention to be harmful, but you never know until the request is made in some investigation and research.
Correct.
I know I was raised in Dayton, Ohio, and in front of our apartment building, this was primarily Black community, there was this huge, humongous television tower that conducted, all the channeling so that we could get the stations and everything we needed. And after some years, people would say, I'm wondering what's going on there, wonder what's happening. And there were a number of, in later years, as some of my young people grew up, you know, development of cancer, particularly among, the women. And people wondered later, I mean, the tower's still there, but the cancer numbers increased, and they're wondering, did this tower have anything to do with it? It's the only one I know in that area, and it's in the community where I was raised. Fortunately, we moved. Our building, our apartment building was right directly in front of the tower. And of course, the tower may have been some distance away, but it looked as if it was right upon us. Does anyone else have any thoughts about that they would like to share, just generally, not to be experts or anything like that, but any sharing of information? Well, if you think of anything, let me know. But I think we'll present this, and it'll be great because Columbia's a partner. You know, some of the grants that come out of Columbia come through our West Harlem Development Corporation, which this community board was extremely instrumental in helping to set up. So,
Did Columbia request the tower right there, or was that something that the organization that installs the tower selected their location?
that's the interesting thing. If I remember correctly, because I know you've gone to some of the meetings, Heather. From what I remember, I think it was the corporation, maybe the corporation paid Columbia a certain amount of money to place it there, place the towers there. There was some agreement. But I don't think they were thinking of it because so many people use cell phones and all that. I don't think they were thinking of it in terms of harm, but it was a designated site and one of them is up. I don't know if they've raised other questions about it or what, but I think the Alliance feels that there they may not be as accepting, but they may just be going along with it because they're being paid.
So are you going to see someone from, I guess, medical center?
Yeah, from Columbia's Science and Data Center is just down the street here.
Oh.
At least that's where Dr. Dye's office is.
Oh.
Yeah, in the Manhattanville campus area. So I think we'll be on to something, again, so often, you know, things are put upon the community, whether it's the sewage, situation at North, what's it called? The North Riverside, River.
Oh, this sewage treatment plant?
Yes, the sewage plant. And then all of a sudden, all of this stench was coming up after a while. This just at Riverside Park at 135th. So many things people do, not necessarily, or not caring, maybe. I'm not sure I'd go that far, but maybe it's convenient and the land is there. So they say, okay, we have to put the waste somewhere, let's put it here. And then in our neighborhoods, not that we don't know, but so many people are maybe busy doing other things and just trying to have a life as well and not understanding or not aware of the potential danger. And so there's a lot more of that now. Same thing with some of the bus depots in our area. And we found after a number of years, the drastic increase in asthma had a lot to do with the bus depots and the idling of the buses in our community. So anyway, I think if we start out with this proposal, at least asking the questions and staying on it and letting our legislators know that we're concerned, that's important. That's a big start. So we don't need to have a presentation to vote on the resolution. The resolution is basically, you know, let's request information and then also have people come in. So we could still vote on this. And if you want to, then we could put this forth.
I make a motion that we present it. to the executive committee.
And is there a second? And Heather second? I'm definitely in favor of it. All those in favor? No. So we're gonna present this. If there's some other, thank you, everyone. If there's some other issues that are facing our community that, you think we need to be aware of, we don't wanna always learn it at the last minute. And sometimes we can't always stand on protocol. It's like waiting for this person to say something or that, because oftentimes they may not say anything, maybe they don't know. Or maybe they don't think we care or are concerned about it.
Right.
Not necessarily meaning harm, but it's information we need to know, because it's amazing the number of calls that will come to the community board asking questions. And we're like, we don't want to be like, what? I didn't know about that. So we do better when we know better, and we can help our community better. So that was it in terms of even in terms of resolution and presentation. So I'm hoping the June meeting can be a big meeting and the weather's great, and some of you that we've seen on Zoom can be with us in person. We'll need to see about a location that we can hold, and because maybe we can make it more of a forum kind of setup with discussion, and give or a wrap up where we have some of our presenters come back and talk about some of the areas where we've made progress. And we have a number of resolutions, maybe have some follow up on some of the resolutions that have made impact in our community as well. And then, of course, we also want to be very supportive we've been mentioning Columbia, but I don't know what's going on, that situation. But our community depends on two, colleges in our area, City College of New York and Columbia University. And of course, there's the hospitals connected to Columbia, Harlem, and Mount Sinai, are all important to this community. So we're hoping to have some feedback and be able to direct our community with the cuts, all the funding cuts. Hopefully they've been, some of them have not been reversed. So and the politics of that, my goodness, we want to just inform our community of what's going on. How do they learn? How do they get the help that they need in a time of cuts? Now that did come up with Columbia, and they wanted to wait through this 100 day period of this new administration. So we'll see what's going on there. Meanwhile, I'll send out their May 27th information on clinical trials and research, because that's one of the, they're supposed to be one of the best in the country doing research. And of course, the funding got cut. And the same is happening with a lot of the major institutions for, again, political reasons.
Yeah.
All right. So thank you for being part of us this evening, joining in with us. And I'll reach out, and we're getting out a lot earlier than usual. And so I can use this time to maybe forward the emails that information pieces that we talked about. I'd like to do that. Okay. Thank you. We can turn off.
So that's it. So we should.
I'll show.
Are we ending the meeting?
Oh my goodness! For us, I need to do a motion.
Right.
Oh yeah, but in terms of the committee, anything else you guys want to bring up? Among the four of us, let's see. Now, Michael has said that he would probably not be here this meeting. I don't know if he graduated. We can hear the record.
So we should make a motion to conclude then.
Okay. Have
Should
you
make a
just
motion?
made a motion?
All right, I second.
Okay, but what I was gonna say is that Michael had said that he might not be at this meeting, because I'm not sure. I know he's getting ready to graduate from law school, so there's a lot of stuff going on.
Yeah.
He also thought that his year was up, since he didn't apply, but I don't think it's really up until after the
Right.
May. I don't know if the names have come in for new members, so it's not, I have to let him know.
Right, so, yeah, we should attend the next meeting.
Right,
We
right.
should attend these meetings if he,
Yeah,
if it doesn't,
but he made a point of telling me.
right, if it doesn't conflict with class. I mean, I know graduation, like you said, is happening, so we can let those individuals know they can jump off, because we've concluded, right?
Yeah,
Can they hear us?
I don't know. Pauline, Joyce, yeah, they're getting on.
Okay,
Uh-huh. Unless they went somewhere to do something and then, came back.
Sorry, did you call me? This is Pauline from the health department.
Oh, I was just letting you know that you guys could jump off. We're just going through a few things here. The meeting concluded at 8 o'clock.
Sounds great. Thank you. Good night.
Thank you, Pauline.
Thank you.
And I will be in touch with you. Let me just write it down. To see an area, and hopefully, is there a phone number? Can you give me a phone number or I can text you? I did have it at one time. I'm not sure I have it now. Or do you want it, or you don't give it out?
No, you can have my phone number. It's 347
Okay.
396
Mm-hmm.
4145.
Okay, because as soon as we can, as we can give you information, maybe we could discuss that a little bit now. Then you could start looking into who would be the presenters, so I can announce them on the agenda.
Okay, sounds great. Thank you.
Okay, thank you, Pauline.
Have a good night. Bye.
Okay.
Send you an email, Emma Bowen. Get a chance to take a look at it, we'll talk tomorrow or the next day.
Okay, yeah, Chris was on too, but it's about what we talked about?
Yeah. Not giving space approval for relocating.
Oh,
did not? Oh, what the heck was that?
and that, but, so,
No, it's still recording. I think we want to stop it and make sure.
I know we talked about it, but let me understand this.
It's already.
It would be a
Thank you.